Dr. Kieran Collison to introduce herself and a little bit about her GP practice.
Hello everyone, thank you very much for the introduction. Hi everyone, I hope you're well and safe. And my name is Kieran, and as just mentioned, I'm a GP. I work here in Oxfordshire, and I also, as part of my work for Oxfordshire Clinical Commissioning Group, which is the organisation that really helps to plan the health services for the county, both in primary care in general, in GP practices, but also the hospital as well. I'm particularly keen to hear everyone's views today, and also the questions that you've got, because if we're going to be able to do some planning and make sure that everyone has access to all the healthcare that they need and the vaccine as well, then it's really important that everyone involved in organising that really knows what some of the perhaps challenges are, or any of the issues are, or any of the questions are, so that we can make sure we get it right, and that we all work together to make sure that we do get it right. So thank you for having me here today.
Thank you, Kieran. Dr. Amar Latif, can I come to you next?
Yeah, of course. Thank you, Nadeem. Thank you, everyone, for inviting me and taking time out of your day to come and hear us speak and have a conversation with us. So I'm a local GP. My normal practice is in Ensham, just outside the city, but I also work in the out-of-hours service out of Munsell Way. I am born and bred in Oxford. I live in Cowley. Most of my family still live here. So I'm very local. I have lots of friends in the local area, lots of family in the local area, and really I'm here to hear what everyone has to say. There's obviously some miscommunications out there, or there's things circulating on social media which might be inaccurate. So really I'm here to hear your concerns, see how we can help address them. I think the key thing that we're trying to do is really, one of the things we know already is that the vaccine uptake in the ethnic minority groups, particularly the Black and ethnic minority groups, is significantly lower than the general population. And that obviously has some significant health consequences. So really it's to try and understand what's, or maybe share what's maybe driving that, and see if we can help increase the vaccine uptake, whilst understanding that people, of course, have valid concerns, which is part of the reasons why they might be hesitant to take up the vaccine. So I'm here to hear what you have to say. Thank you.
Thank you, Dr. Amar. Dr. Shamila Wananyake, can I come to you next?
Hello, thank you, and thank you again for inviting me today. I'm a GP in Oxford, and I work at the Manor Surgery, which some of you know is sort of on the grounds of the John Radcliffe Hospital. I've been a GP now for 8 years and a doctor for about 17. I was actually born abroad. I was born in Sri Lanka, and I think by the time I was 11, managed to emigrate 3 times. So I've sort of got family all around the world with varying different backgrounds. It's always really interesting to get different views and different opinions, and to hear the different stories about what's happening, what's out there, and what the misconceptions and what the truths are. I've got no declarations of interest. I do not work for any private initiatives, big pharma, or have any stocks and shares in pharmaceuticals or anything like that. I also participate in clinical research from my practice, where we undertake studies that we feel most benefit our patients and populations. And with a background in research, long before I even became a doctor, I had a natural tendency to be critical of big pharma research, and I spend lots of time reviewing and analysing the other side, and I did a lot of this with the vaccine data too. I do believe it's good and healthy to have a degree of scepticism. However, I think it's also important to have that we really look at what we do and find the best evidence that we can to benefit our communities. And I think this is really important in the conversation that we'll be having today, that we're looking at the evidence, not at the misinformation, at Twitter feeds and media, but actually the facts and figures in this sort of rapidly evolving situation. So thank you.
Thank you. And Dr. Mary Akinola, can I ask you to introduce yourself?
Hello, everybody. Thank you for the invitation. Just to say, I'm a GP in Oxford. I work in Botley and Kennington. I've been a GP for the last 20 years and worked mainly in Oxford. I also am involved in research. I'm actually at the John Radcliffe now, working mainly on neurodegenerative research, dementia and Parkinson and other research, as well as working within the practice, again, as Shamla said, for research that to do with benefit patient in general. Background, I also have family around the world, was born here, went to Nigeria, America, and then back here. So again, had that kind of wide contact. And just very recently, I've been involved, or trying to be involved with issues that affect the Black and ethnic minority. Earlier in the day, we had a conference call with the refugee and the women's group within the refugee, and it was quite an interesting session. And again, just to exchange ideas and to say that we're in this together, and whatever the concerns are, we hopefully will be able to sort it out together.
Thank you, Dr. Mary. Okay, so if you just look at the bottom of your panel, it says participants. If you have a question that you want to ask, can I suggest that you press the blue hand, and then I will come to you. But just to get us going, I'm going to ask the first question. So I'll come directly to Dr. Kiran. And my question is, how safe is the vaccine?
Hi, thank you for that. So what we know is, and what we should, I think, be reassured by, is that the vaccine in the trials that they've had have shown that the vaccine is safe and effective. And at the moment, we're predominantly using two main ones, the Pfizer vaccine and the Oxford AstraZeneca vaccine. So when I talk about vaccines, those are the main ones I'll be speaking about, because I know most about them. So I think some of the concerns that do come up is that these vaccines have been developed very, very quickly. And so some people say, well, we've heard that vaccines can take years to develop. And if this has been quite quick, does it mean that it's not as safe as other ones? Which I think is a really great question to ask. And I think the reassuring thing about this is that, yes, it has been quick, but I think it's really because this is a global pandemic and it's like nothing really we've ever seen before. So every effort has been thrown into this. All the stages have been gone through as any other vaccine would, but they're doing some of them in parallel. So rather than do one over a period of time, then the next, they're trying to do as many of them in parallel as they possibly can to be as time efficient as possible. And no corners have been cut with any of this. It's gone through all the rigorous testing and all the processes that it needs to go through to ensure that it is safe. And they've had thousands of people in the trials, absolutely thousands across the world. And they've been looking at the effect on them in terms of side effects, and also in terms of how effective the vaccine is as well. And we know that both vaccines are highly effective and also very, very safe. Sometimes people do ask about the side effects and they're worried, will they get side effects from a vaccine? The most common side effects are a sore arm. Sometimes people might have a bit of a flu-like illness, usually mild. And other than that, it is absolutely fine. So I know there are also lots of concerns about safety in general, about the constituents of the vaccines as well. I certainly know from some people they're worried about meat products and perhaps alcohol in it, whether it can alter your DNA. I've heard that people being worried about that, whether it's got fetal cells in it. There are many things that people I know have heard about and are worried about, but none of those are true. The other one is that people are worried that it might impact on fertility. And again, that is not true either. So I hope that helps to reassure. It's been through rigorous testing, through the trial process. Those specific issues have been addressed. And I hope that this helps to reassure people to an extent, but happy to go into further detail on any of that if anyone would like.
Okay, I am going to call over to Dr. Mary Akinola, who has her hand up.
I just wanted to say about the different stages that Kieran was talking about, the different phases that a study or a trial will go through before it is able to be used. So you have the phase 1 studies. Even before that, you have the preclinical studies where they work maybe on animal models, exposing them to the disease and trying them on the vaccine in this case. And then you have the phase 2 studies where small groups of people are given the vaccine to see what happens. And then the phase 3 studies, which is what we usually need, where thousands of people, and as Kieran said, in different countries, in this case, UK, America, South Africa, and Brazil, and Turkey in the Oxford study. So thousands of people that have been exposed to the vaccine to be able to get the information. Obviously, when you have thousands of people in the studies, you can't compare it to millions of people, but everything has to be done with a bit of faith. At least the information we have so far is proven that it's safe and effective. And as you roll it out, you may get other things that you haven't gotten, but so far the basis is that it is safe in the people that's been tested out on. And actually, even from the UK, with 5 million or more vaccines, we haven't had any major evidence of side effects. So that again shows that it is safe. And also, we have a continuation of monitoring as we're giving out the vaccine. We have a mechanism. If we know a patient that was vaccinated, if they have various complaints, we can also flag it up. So apart from the previous work, the continuous work of monitoring to actually monitor the safety of the vaccine. That's what I wanted to say.
Thank you, Dr. Mary Akinola. Before I go to Shamila, then Tony, Junie, you've put 2 questions in the chat box. I think the first one has just been answered by both Dr. Kiran and Dr. Mary Akinola, but I'm going to read those out so you can correct me if I'm wrong. So your first question was, can you tell us what are the known side effects of the vaccine, given the speed at which the vaccine was developed? And I think that was answered, unless you're saying otherwise, and then I will go back to one of the GPs. But the second question, which I think is quite an important one, what possible compromise with other medication someone is already taking? So I think what possible compromise could the vaccine have with other medication that someone is already taking? So Dr. Shamila, can I come to you on that one, if you could answer that question?
Yes, you can indeed. And I'm wondering if it sort of fits in with one of the other bits that I wanted to talk about, which is something people often ask me is what is actually in the vaccine, because obviously that also is what can sort of play into what we think might interact with something else. So firstly, we're not aware that there is any interaction with any medication that people are taking. And please correct me if anybody else has any other intel on that, but it's not, there is no medication that is contraindicated with the vaccines. Also, what's in the vaccine? So the main ingredient is water, and that's usually what's in most vaccines. You will always get a little bit of preservatives and stabilizers, but these are often naturally things that help to maintain the quality of the vaccine. It enables safe storage and it prevents contamination. And these will be substances such as sorbitol, which is a naturally occurring carbohydrate that you get in fruit, for example. It will have the active ingredient, which will be a little bit different depending on which vaccine you use. None of them have any animal products whatsoever. You will have an adjuvant, and this is something that helps the vaccine, it helps your body to create a stronger immune response. So this will often be, again, naturally occurring substances. One of them might be so I think in some sort of residual traces can be found in drinking water at higher levels that will be found in the vaccine itself. You can also get certain residual traces of substances that have been used during vaccine manufacturing. And one of these, which I've also come across as people being concerned about, is alcohol. However, the amount of this that is found in the vaccine is pretty much less than that which you'd find in your supermarket shelf bread, for example. So these are really, really tiny quantities. And as I said before, there are no animal products at all in the vaccine. So this was one of the questions. Now I've had the vaccine, and I actually grilled the the doctor that consented me, who was one of the immunology registrars at the Churchill. And he pretty much said the same thing. He said, you know, there isn't anything weird or wonderful in these vaccines. They're all pretty standard things. And so actually the risk of any kind of serious reaction is so minimal, and the most common reactions will be a bit of pain in the arm. I actually had, in the first 24 hours of one of my second dose, I had a slight fever, but that settled down, and my arm ached a little bit, but other than that, nothing else. What they are saying is that if there is anyone who's had any kind of serious anaphylactic type reaction, so these are the individuals that at this current stage should not have the vaccine. However, there are such small, tiny numbers of these, and they recovered very quickly, and we haven't had any serious events in this country really at all. So far, considering the number of people that have been vaccinated, we haven't had any serious consequences at all. So I hope that answers that in some to some respect.
Nadeem, I think you're muted if you're trying to talk at the moment.
Yeah, Tony, if I can come to you next, and then I'll call to Richard's questions. Tony, can I come to you first?
Yeah, sorry, just to unmute myself. I'm a little bit baffled by all this. Sorry if I sound a little bit. I'm totally aware of people being, you know, a bit scared about the vaccine and stuff. My mum and her friends I know of have actually been quite, they just want to get it done. My mum's got hers on, her first one on Saturday. I think if she could have it today, she'd have it today. What I've been doing with people who've been a bit doubtful about the vaccine itself is just basically asking them if they know anybody who's got smallpox or polio, and they will say no. And I'm like, yes, that's because they've had a vaccine for it. And then I have conversations about, people questioning what's in the vaccine, and I kind of go, all right, nobody questions what they're smoking, nobody questions what's in their booze or how they make wine. Yeah, they just drink it. But what I do want to know about this vaccine though is basically how many people are turning it down, and when people have turned it down, how are you doctors dealing with that? Because if people turn it down basically on the day, if they come to see you and then just go, you know what, I can't do this, how have you convinced them? Because I think I keep hearing, but there's I hate the term BAME, but there's this BAME backlash. Most people I know, man, they would take it tomorrow if they could get it. But for those who don't want to take it, how have you convinced them 24 hours before on the day that, this is it, let's go?
Thank you, Tony. Dr. Amar, can I come to you?
Yeah, I'll take that question, Tony. Great question. So I think it's important when we look at, if we use the word BAME, as I say, I know people have mixed feelings about using that, but hopefully we all can accept it during this meeting and understand what we mean by it. One of the reasons we think that the uptake in this population is lower is really because we know that there are inequalities in access to health anyway. So anything that we offer to the general population, we know that actually some populations will take up at a lower rate. So that's one of the things that we know. There's just an inherent inequality in some ways, and that's one of the reasons we're holding these meetings, is really just to encourage people to come forward and say, yes, actually we do want it, because sometimes it may not be someone has declined it, but they may not have come forward in the same way that other people have. So that's the first thing to say. I haven't personally found many people when they come to the clinic actually saying, I don't want this, I don't want the vaccine. Now, there's a few things to consider here. So one is that actually the way in which we're booking patients in is there's groups of practices that are coming together. So typically 3 or 4 practices together, just because of particularly the Pfizer vaccine, the way that the logistics are, is you can't do it on an individual practice basis. You need to do it as a few practices coming together, because essentially you get 3.5 days from when the vaccine arrives to use up all the vaccine. So because of that, most people, we will normally have some sort of discussion when the patient is being booked in, normally with the admin team, maybe with the clinician, to say, are you happy to have the vaccine? So in some ways at the moment, what we're finding is that actually it's people who are self-selecting and coming forward. The ones, I've had very few patients who have said no, and the ones that as I say, no one in the clinic has said no to me. The ones that have said no elsewhere, normally it's a little bit more subtle than that. The reasons are often, I've got a couple of patients who are very palliative. They've got maybe a cancer diagnosis. They don't have long to live. And so they say to me, look, is it really, is it really something I should have? And of course, there's no right or wrong answer. So I think that's important to say. The other thing that I think everyone is anxious about a little bit is, you're right, I don't know how old your mother is, but I'm assuming she's over 70, because actually at the moment it's only 70-year-olds and those in the shielding category who are able to have the vaccine on offer to them, and health and social care workers. And in some ways that group is more likely to say yes, because we know that they have higher rates of mortality, unfortunately, and we know that a lot of them have been shielding to some extent, even if they weren't in the shielding category. So a lot of those patients are less likely to say, no, actually, we don't want it. What I think people are a lot more worried about, certainly healthcare professionals, is as we get through that group. So we've done, I think, to date, about 9 million people in the UK. Today, I'm pretty sure we'll hit the 9 million mark. We're hoping by the end of next week, we'll have done everyone over 70. So that's about 15 million people over 70s, health and social care workers, and everyone on the shielding list. And then as we start moving down the age cohort, so it'll be the over 65s next, then the over 60s, then anyone who would normally get a flu jab, we're worried that actually that group might not come forward. So that's really why we're trying to get the word out there to explain what happens with the vaccine and what the side effects might be. So I think that's important to say. The other question I saw, someone had a question, I forget who, my apologies, in the chat box about allergies specifically. It was Richard, I think, Richard. Just to pick up on that question specifically. So the allergies are kind of broken down into two things. So one is an allergy where you might have kind of feel unwell after a vaccine or a medication. We tend not to call that an allergy as healthcare professionals. We call that really a side effect. What we're really more worried about is if you have a true anaphylactic reaction. So that might be where it affects your breathing, your tongue can swell up, your lips can swell up, and you can have, end up in hospital needing adrenaline and oxygen and so forth. So when the Pfizer vaccine came out, what they tend to do with these vaccines is they roll them out in hospitals first. They have hospital hubs. There are about 51 around the country. Oxford at Churchill was one of them. And what they do is they do them there because it's kind of an environment where they can supervise people and see, is there a reaction or not? And in the first week of rolling it out, they found that there were 2 people who did have an anaphylactic reaction to the Pfizer vaccine. So as a precaution, they said, if you've ever had an anaphylactic reaction to anything in the past, you should avoid the Pfizer vaccine until we've rolled it out into more patients. And actually, by this stage, early January, actually, we'd done a few million by that stage. Actually, the rate of anaphylactic reactions was very low. And then they looked at it more closely and they found that only people really having an anaphylactic reaction were those who'd had an anaphylactic reaction to a substance in the vaccine, a component of the vaccine already. So then they changed the guidelines. They said you should only avoid the Pfizer vaccine or the Oxford AstraZeneca vaccine if you've got an anaphylactic reaction to one of those components of the vaccine specifically. So a lot of people will have reactions to nuts, peanuts, nuts, wasp stings, penicillin, other medication. And if you've had an anaphylactic reaction to those, then it's perfectly safe to still have these vaccines specifically. The only caveats to that, there's 2 caveats really. One is if you don't know what the reaction was to. So some people will say, oh yeah, I remember when I was young, my parents told me I had an anaphylactic reaction, ended up in hospital, needed adrenaline, but I don't know what it was to. I had a patient who just at the weekend on Saturday in clinic, she said, I had a reaction to a vaccine that they were trialing at the time, ended up in hospital, needed adrenaline, but I don't know what it was. So anyone where the source of the anaphylaxis is not known, they're recommending avoid the Pfizer one and opt for the AstraZeneca one. And then the other group of patients is there are some groups of patients, very small numbers, but there will be a few out there who have lots of anaphylactic reactions or serious allergic reactions to lots of different medications. So they might have wasps, nuts, penicillin, plus 1 or 2 other things. And they're saying even in those instances, even if you've not had an anaphylactic reaction to a component of the vaccine, it's better to avoid the Pfizer one in those instances. So they're the only two caveats really, but otherwise we know now, we've rolled it out in 9 million people. We know the rates of serious harm are quite low. You know, my colleagues before me have already explained what some of the side effects are. So hopefully that helps address those questions.
Thank you. Imadi, can I come to you next?
Good afternoon. I've taken the vaccine, so I've taken the Pfizer vaccine, so I know, well, I'm healthy. I only had a sore arm and a little bit of a headache, so I can say categorically that I think it's safe. My question actually is for Dr. Amar and Metruja himself. One of the problems we have that people talk about from the BAME community, why people are not ready to take the vaccine and don't know much, is because one, there's lack of trust. And this is history, it's been going on for years. That's the big problem. So the question is, what can the council do, right, to kind of fight not only the misinformation out there, but try and work with the local community leaders. For example, I'm here today because Leonard called me. I see his face, I understand him, so that made me feel confident to come here, you know, and have a conversation. There are many people in my community that will not come to a place like this because they don't have the trust. So I'm asking, what can the council do, and how can they, you guys do something to make sure we can reach the leaders of the community? You know, what can you do about that? For now, we have another one. I know Oxford City Council is kind of helping on a project coming up on the 13th, you know, still people trying to talk about the vaccine, which is going to be hosted by Oxford Community Action and African Heritage. So for people like organizations like that, what can they do to make sure it's done properly? That's my question.
Thank you, Imadi. I'm certainly not a doctor, by the way. Okay. If I can just respond to that point. I mean, I think you partly answered your own question, because I think that it's really important that we really really think about the value that Lenny holds in the community, and actually those relationships that he actually holds in the community in terms of having conversations like this. And I think what's also important is that these conversations are actually held with people who actually know the facts. That's why the general practitioners are here. And it's why we want to actually have this conversation recorded, so you can actually ask these questions in the most authentic form. As I said, there's no right or wrong answers. We can record that information, and we can actually then share that conversation wider to the community. I think it's taking small steps, but it's taking quite important steps. And, you know, we're not going to change everything. The points that you make in terms of trust, belonging, etc. You know, I think literally everyone on this call is principally from a BAME background. And actually there are issues that we can all actually connect and relate to, but the only way we're going to actually get through them is through actually having this kind of dialogue in the most authentic form. I'm going to move us on to some of the other questions that are actually in the chat box. And then I'm going to go to Dr. Kiran, if I may. So I think we've already covered what's actually in the vaccine. I know Richard asks, is Wikipedia wrong? I'm not sure if we can say is Wikipedia wrong, but I do think Dr. Shamila clearly outlined what's actually in the vaccine, and no other colleagues also did. But I think this question from Marcel is quite an important one. What's the predicted impact of delaying the dose? So that's, I think, the differentiation between the first jab and the second. And was this actually any different to the research that was actually undertaken? Before I ask Kiran to answer that question, I wondered if I could just take another question as well. So if I can go to, no, the hand's dropped. So Kiran, can I come directly to you?
Yeah, thank you. So this relates to the vaccine being given in 2 doses. Originally, back in December, we were being all advised to have the first vaccine and then the second vaccine 3 weeks later. The guidance then changed towards the end of December to say that it won't be a 3-week gap anymore. It will be extended to 12 weeks instead. So the reasoning behind that was that we were seeing people ending up in hospital, people dying on a huge scale across the country. And the thinking was, if we can protect more people quicker, then that's got to be a good thing. So the decision was, either do you give more people their first dose, which has a high level of protection in itself from one dose, or do you give half the number of people protection by giving them the 2 doses, if that makes sense. So by giving the first dose and delaying the second, it means that more people, really double the number of people, have now received a vaccine that would have done otherwise. And that means they're potentially protected, which means that they'll potentially not end up in hospital and potentially not die. The question really here is about, is that what they did in the trial? And is this an effective way of doing it? Is it still going to offer protection? Well, I suppose first thing to say is that we do know that there is a high level of protection with 1 dose. And it's slightly different for the 2 vaccines, or it's very hard to compare them directly because the trials were slightly different. But just to say that they both got very high levels with the first one, and that gives protection in the short term. And it's the second dose that is thought to give you the longer term protection. So if we can have as many people having the first dose now, at least more of us will be protected in the short term. And then when the 12-week one comes around, we'll be given the booster, which will then give us longer term protection. The trials themselves, particularly if you look at both of them really, but the Pfizer one in particular, the recommendation came out to have them 3 weeks apart. And the AstraZeneca one was similar, although in the AstraZeneca one, they did have an arm which was slightly longer in the gap between the first and the second. And interestingly, with the AstraZeneca one, what they found is there were some slight differences in how effective the vaccine was when they gave it in slightly different ways. And the one where they actually stretched out the dose interval, in that particular part of it, they actually found that the effectiveness was greater than when it was shorter, which is really interesting. So overall, if you look at how it works, having a slightly longer gap between the first and second, I think on balance was thought by the people, the chief medical officer who sort of looks at all the science. It was thought that actually on balance, looking at the trial data and looking at other vaccines and how they work, that extending it would be a safe thing to do and would still make sure that the vaccine still was very effective. And at the same time, it had the dual benefit of protecting more people by getting more people vaccinated with the first dose. So overall, I think it was a tough decision, as far as I can tell from all the conversations I heard at a national level around this, because if there's a slight deviation away from a trial, it obviously does get people looking into it more and it has more scrutiny around it. But on balance, that was the decision they came to, so more of us are protected, and then we will then go on to have our second dose and have the longer term protection that the vaccine then offers.
Thank you, Dr. Kiran. Okay, I'm going to go to Dr. Mary Akinola next. But before I ask you to respond, can I just add a question? So what impact does the vaccine have on people who are planning to get pregnant, possibly breastfeeding, or pregnant? So I'll go over to Dr. Mary Akinola to answer those questions. And you're on mute.
We were just discussing that earlier, actually, and I was looking at the guidance again. And like most in medicine, you have to talk about the risk and the benefits. So the guidance says that although they haven't got any information about the risks on pregnant and breastfeeding women, if a pregnant lady or a breastfeeding woman is on the at-risk group, i.e. healthcare professional, also clinical, extremely vulnerable, maybe a transplant patient and things in those groups, then it may be thought that the risks or the benefits rather are higher than the risk. And in discussion with the clinician involved, that person can be vaccinated. So we wouldn't say every pregnant woman should be vaccinated or every breastfeeding women can be vaccinated, but on a one-to-one risk-benefit ratio, if it is thought that the risks of having the disease, if you're frontliner working with people that have the disease, then it may be thought that having the vaccine would be the best decision for that person. So there's no general rule about pregnant ladies and breastfeeding women, although I've read it again yesterday when I was just looking at this. I think that breastfeeding women can have the vaccine. They haven't found any harm to the baby, but you have to look at a one-to-one basis to be able to make that decision, depending on the specific situation of that patient.
Thank you, Dr. Mary. I'm going to go to Dr. Amar. And can I just ask you an additional question, Dr. Amar, that you may want to answer? Can the vaccine affect fertility?
Yes.
So I'll answer that first, Nadeem. So no is the answer. So the thing with a lot of these things, as Mary correctly said just now, but also in her first answer, is that often it's difficult to get definitive evidence for something. So we can't prove something, but on the balance of probabilities, things are unlikely. So, you know, if you ask about pregnant women and the effect on pregnant women, well, the reason we don't have evidence on that is if you're trialing a new vaccine, most pregnant women will probably not come forward, and we would not recommend it to be part of the trial, because actually that would be, you know, that would, if there were harms to the baby, that would be a bad way of finding out. So it's the same thing really with fertility. There has been a lot put out there about affecting fertility. There is no evidence at all that it affects fertility. In line with most of the vaccines, there's no impact on fertility at all. I just wanted to come back on 2 points, if I might. One was that Amade made and asked me to comment on really about the lack of trust in healthcare. And I think it's spot on, Amade, your point that, look, if we are honest, if we look back in the history of medical trials, we know that there have been groups of patients, particularly from the BAME population, who have been recruited into trials without ever knowing they were in a trial. You know, if you read some of the history on this, it really is quite atrocious. And so it's natural that actually people from that group and that community, including myself, we feel a little bit reluctant about, well, what does this mean? You know, is this part of a great big scheme to do something? I think your question really was about how do we get out to the average person? And I think it's a very fair question. So, you know, I was asked this last week to put a video together by the local mosque where I attend, and, you know, most of the community know me. And that got circulated on social media to say, look, I know lots of people in the local community. You know, my father's lived in Oxford for about 50 years. If there's someone of a Pakistani background, they probably know me or my family in some way. And so I've put out a video saying, look, I do believe there's no significant harms. And if that's the case, then please, you know, get in touch with me. Most people in the community have my contact details, either directly or through a family member. Get in touch. And since then, I've had quite a few members of the community get in touch and say, I've got this concern about my parent or my child and so forth. What do you advise? So I think that's the only way we can do it, really, in these sorts of events, to get out there and to have people who are from the community coming forward. If I might just quickly address Richard's point, which he raised in the chat question about the delaying of the vaccine, and Kieran's completely right in her answer. I think we need to be absolutely clear when we're looking at the delay in the vaccine of the second dose, why it went from 3 weeks out to 12 weeks. What was the purpose of that, and why have not all other countries followed it, and why might, you know, there be some debate, which there is a little bit in the medical world about this. So the important thing to say is that in the AstraZeneca trial, the Oxford one, there were some groups of patients, there was an arm of the trial where they did have a second dose at 12 weeks. And we know for them that actually it was largely quite effective. And as a general principle, most immunologists will say that if you delay the booster jab in lots of vaccines like hepatitis B and so forth, there's actually good evidence that if you delay it, you tend to get a better immune response. The Pfizer vaccine, the trials were all between 3 and 6 weeks, so 21 to 42 days were generally what the trials held. Most people didn't have the second jab outside of that. So then the obvious, really fair question is, well, why suddenly are we all getting it after 12 weeks instead of 6 weeks? And I think the trade-off is absolutely critical that we all understand this, that we are taking the vaccine to help protect ourselves. but we are also trying to protect everyone around us as well. Now, what I mean by that is there's no evidence that having the vaccine prevents you passing it on. But what we know from the trials is that the number one thing the vaccine does is, if you still get it, which is still a possibility, the chances are much less, you are much less likely to actually end up in hospital. Okay. And so that is a really important point. So what they actually did was they looked at the Pfizer data and they did a sub-analysis. So they said, okay, let's look at everyone in the Pfizer vaccine, including those who got COVID after it. And this comes back to Richard, your link that you've put in there about the Norwegian experience. They said, look, if you've had the vaccine and then you get COVID or you die or you have a serious reaction in the first 2 weeks after the vaccine, well, we know from looking at people's antibody levels that the vaccine hasn't worked in the first 2 weeks. It takes a bit longer than that. It's not like paracetamol, you know, now down the line it's worked. It takes about 2 weeks for it to work. So they said, look, if anyone had COVID in the first 2 weeks, that wasn't because the vaccine failed. That was actually because it was too quick. They probably were going to catch COVID anyway. And so they looked at the proportion of people who got COVID after 2 weeks after the first jab, and also after 2 weeks after the second jab, because at that stage, the second jab hasn't been effective. And they found when they did the sub-analysis that actually the effectiveness rates were about 89%. So I don't make these decisions, the government does, chief medical officer. They got a very difficult decision to make here. Are you better off giving a few people better protection, or are you better off for the population as a whole protecting lots of people from ending up in hospital, maybe not getting the full benefit individually that they might do, but at a population level, actually that would still serve a purpose. And that, I think, is the decision that's been made. So, you know, that there are, as I say, with the Oxford AstraZeneca trial, there was good evidence that 12 weeks probably still confers a lot of benefit. Less so in the Pfizer one, but actually, when you look at it from the immunologist perspective, the people who do a lot of research in this, actually, yes, it might, we don't know how much the benefit is. We think actually by delaying it, it's probably around 89% effective still. So still fairly effective. It drops from about 94% to 89%, so still very effective. But the key thing is that what we're doing is we're preventing people turning up in hospital, which has a bigger impact on everyone else around you, because the more people that are in hospital, if you have a heart attack, the less that chance you have of getting the correct medical attention and all the knock-on impacts that we have. So I think it's fair to question, look, why have we gone for 12 weeks? But I think we should explain to people that the reasoning behind this is we're trying to protect the larger population. And as Kieran said, the difficult decision that was made was it's better to protect more people or give some protection to more people than give more protection to a much smaller cohort of people.
Thank you, Dr. Amar. Okay, I have two questions, and I'm going to go to Dr. Schmiller next. So the first question is, if you've had the vaccine, do you still need to social distance? And the second question is, if you've had the vaccine, will it protect you from the flu? So I'll go to Dr. Schmiller for that one.
So your first question about social distancing if you've had the vaccine. So with the vaccine, it does not necessarily mean that you are completely immune from COVID. What we're trying to achieve here, as Amar correctly pointed out, is this concept of trying to vaccinate as many people as possible so that they at least have some kind of antibodies against the vaccine. So it's this concept, I suppose, of herd immunity. Now, with herd immunity, you need the majority of people to have had the virus. What this often means, it doesn't mean with a vaccine that you cannot get COVID. What it means that if you do get COVID, it is much more likely that your symptoms will be significantly reduced. And what we're hoping is to a level where you don't need medical attention, where you don't need to go into hospital, where you can be managed at home safely, and your immune response is not so severe that you have all the nasty effects that we see and hear about. So that's the general aim of the vaccine. Now, we know probably about maybe 2 million people have possibly had COVID. Then this is probably an underestimation in the UK. and we're looking at a population of about 68 million people. So we still, so there's a lot of people that need to that need to have either had COVID before we can even think about releasing or relaxing some of the measures that are now being put in place. Therefore, even if you have had the vaccine, we are still recommended that you take all the necessary precautions, and that includes wearing face masks as per the government guidance. It still means that having social distancing, really whatever is applicable and relevant in your area, and that the government has advised you to do. And that's because we still can't be it doesn't compete. What we're trying to do is there are a lot of people who still are at risk of COVID, who have not had the vaccine and who are very vulnerable. And it's really important that we protect those people as much as possible. So even if you have had the vaccine, we're still absolutely recommending that we do maintain the precautions that are being advised in whichever areas or regions that you are coming from. Those precautions, the different tierings, the different tier systems and lockdowns, they're all based on data that's being accumulated in that particular area, that's looking and tracking over time what the rates of infections are. And what we're hoping, and what we particularly hope to see when, as we vaccinate more and more people, that rate of infection, that rate of transmission starts to come down. And that's what we're aiming for, so we can at some point in the future look to have, to getting back to having our normal lives back, which is what we very much all want. So I think the simple answer is yes, we need to still we still need to do all the necessary precautions that we're advised to do, even if you have had the vaccine. So I hope that answers that.
It is. And the second question was, does the vaccine protect you from the flu if you've had the vaccine?
So no, the vaccine does not protect you from the flu. So there is a separate vaccine, that is the flu vaccine, and they both have their own indications. And so no, it does not protect from the flu, I think is a simple answer to that. So if you are eligible for the flu, and your GP practice will advise you whether you are or not, depending on your various medical problems, we still strongly advise you we advise you to have both your vaccines, or any vaccine that you would normally have. Because there isn't a crossover. The COVID vaccine is very much for COVID, and the flu vaccine is very much for the flu. There is, however, some data which just show that if you do get the flu, and then you do get the COVID virus on top of that, the risk of complications from that is severely it's a lot worse. So if you have picked up the flu, and then you get COVID on top of that, then there is your risk of complications goes up, which is why we still recommend everybody to have their flu vaccine as well.
Thank you, Dr. Ishmael. Dr. Mary, you've got your hand up. Is that a new hand or is that an old hand?
Sorry, that's an old hand.
No.
I'll put it down.
Fantastic. Okay, I think they're pretty much all the questions that I have had. I can't see anybody's. In fact, I've got a hand. Paul Wilson, can I come to you?
Yeah, hi. Yeah, so it's Paul. Yeah, so I've had the vaccine. I just basically got a text on my phone, followed the link through, booked the appointment. It's all very straightforward. My question though is, will the appointments be offered on an out of hours basis as well? Given that I know that a lot of the people from the BME group work in key worker roles and have to physically go to a workplace. Some may just say, well, I'm not going to go if I have to take time off work unpaid.
Okay, let me go to Dr. Kiran for that one.
Yeah, that's fine. Thank you for that question. So vaccinations are being offered in different locations, as you may already be aware of. So some are done through through general practice, And I think, as Dr. Latif said earlier, collections of practices coming together. So some are delivered in that way, some are delivered through bigger centres. So for example, in Oxford, the Kassam Stadium has opened as a big vaccination centre. There will also be over time some pharmacy sites as well that will start to deliver the vaccine. So that just to sort of set the scene there in terms of where people might get the vaccine. In terms of the hours, yes is the answer really to your question about the out of hours evenings, weekends. That is already happening. A lot of when the vaccine comes very much depends on the supply as well. So in terms of actually giving people the vaccine, as you may know, it's really dependent on it coming through from central stores out, delivered to all of us. And that then really determines when we can give the vaccine. So if it happens to arrive on a Tuesday, for example, clinics will be set up for the Tuesday and the Wednesday, as an example. Sometimes they arrive later in the week, and that will mean the clinics are set up on those days. But throughout all over the county, clinics are running at weekends, and the big mass centres are also running evenings, weekends. So that is definitely taken into consideration. And the reason why is exactly as you say, not everyone can necessarily get there between 9 and 5, Monday to Friday. And it's so important that the more people have the vaccine, the better. So if that can be opened up as much as possible, that's got to be a good thing.
Thank you, Dr. Kiran. Two quick questions for Dr. Amar. So the first question is the vaccine halal? And the second question is, if a patient is COVID positive and they're in a priority group, how long do they have to wait before they can have the vaccine?
Thank you, Nadeem. So yes, it's halal. There was some misinformation put out when the vaccines first became available, saying that they had animal and pork products within the vaccine, but that's not true. Most of the large Islamic organizations, all the Islamic scholars, the medical doctors, including organizations like the British Islamic Muslim Association, have all come forward to say, yes, it's completely halal, and yes, it's perfectly acceptable to take. As a side point, a lot of, or some patients who are having the vaccine now, the second question would obviously, second vaccine dose will obviously be at about 12 weeks. And that will probably fall into the month of Ramadan, which is happening from about April. So actually there is, again, a widespread agreement that having a vaccine does not break the fast. So having injections, lots of patients might have insulin or other injections. Generally, that's permissible and allowed. So that's not something that would break the fast. In terms of your second question, which I happen to have forgotten, Nadeem, just remind me. Your second question? Oh, you're muted. Sorry, Nadeem.
Okay.
Oh, I got it. The COVID vaccine.
COVID positive.
COVID positive.
Yeah.
Excellent. So how long should you wait? So again, there's guidance and there's what might be applicable to an individual. So the guidance says at the moment that if you've had COVID, you might want to wait for up to 4 weeks before you have the vaccine. Now, the reason for that is important to understand. It's not because necessarily your illness will be affected by having the vaccine. The reason is that actually, if you have the vaccine and you've had COVID, let's say in the last 7 days, with COVID, we know and have begun to understand that it's not like most illnesses. You know, if you've got a chest infection, you're really bad, and then slowly you get better. And with COVID, what happens is most people are not too bad in the first week, and it's the second week when there's the biggest risk to them. So if you have a vaccine in the second week, what we don't know if you end up having a reaction to the vaccine is, have you just had a reaction to the vaccine, or is it because your COVID is getting worse? So there's been some guidance put out there saying that actually, if you have COVID, it may be better to wait 4 weeks. It's not an absolute contraindication though. So there will be some patients, I've had patients in my clinic, one chap was 10 days after COVID. And I said to him, look, this is the window where if you get worse, it could be because of COVID. And if you get it after the vaccine, we don't know which it's going to be. And he opted to wait. There was another patient I had who'd had it for 3 weeks, but hadn't had any symptoms, just had a positive test. And I said the same to her. And she said, well, actually, I've not had any symptoms. So if I get a reaction, it's probably going to be the vaccine. And now it's 3 weeks rather than 7 days. There is a feeling that if you've had COVID, you get some immunity from the fact that you've had the illness. That's true of most illnesses. How long that lasts for, we don't know. And that's the tricky thing. There's some research from last year to suggest that it might be a matter of months, that you get some immunity for, but we genuinely don't know that just yet. So the advice is, yes, you can have it. Speak to your healthcare professional, your doctor, to try and work out, is it better to have it earlier or later? As I say, the guidance says you may want to wait for 28 days.
Thank you, Dr. Amar. Okay, I don't think I can see any other hands. Give me a second. I can't. There's a question, it's a more generic question that Uton has put into the chat box, which basically is about the disproportionate impact. So Black and ethnic minority communities have for decades been subject to a different level of inequality. And what COVID has done is actually just really shone a light on those inequalities. It's really exacerbated. We've actually seen points from mortality, and the point that Dr. Amar made earlier in terms of the way vaccine tests have actually done historically in the past, just only just shone a light in terms of why we actually have some of those trust issues probably in this contemporary sense. And I think what Uton's really asking is, given what's happened, given the wealth of evidence now in terms of these inequalities, what do you think really needs to change so the predicament or the hurt, the pain, the loss of life, it doesn't repeat? What do we need to do to really actually tackle some of these inequality issues? And how do we actually build trust between institutions and BAME communities? So that's quite a broad policy question. It's not the reason why you attended, but I think whilst you are here, and given that we all work for respective public institutions, you know, I'll hold my counsel and go last. So I'll first go to Dr. Shamila, and then we will take a brief contribution, and then I will give my views, and then hopefully we will conclude at that moment in time. So Dr. Kiran, sorry, Dr. Shamila, if I can come to you first.
What I was actually wondered whether that might be, if I might defer that question to one of my colleagues at OCCG, as they've got probably the wider overarching view of what's being tackled at a greater level. So I'm very much a sort of grassroots GP who's sort of at the bottom, you know, trying to work out how can we best support our communities, and so if you don't mind, I'm going to defer that actually to the levels higher up me. That's okay.
Thank you.
They will be involved in policy decisions. I'm not, unfortunately, so I'm sort of really on the bottom rung of that ladder. If that's okay.
I'm happy to come in if that's all right.
Yes, sure.
Do you want me to say something on this?
Yes, sure.
I think this is such an important question, and I think what we've found is that COVID has highlighted an issue that's so much wider than just coronavirus. And there have been inequalities for years, in fact decades, and as you say, this has shone a light on it. What worries me slightly is that we've had the inequalities, COVID's come along, it's widened the inequality further, and now we've got the vaccine. And what I really would worry about is if that widened it even further, because some people are taking it up and others don't. So that's really the context that we're in. So there have been some sort of high levels of policy discussions about this. It's about time that this is tackled. You know, enough's enough. You know, what does it need? What does it take to actually get on and try and tackle this? And we've finally reached a point where people are sitting up and they're listening. So I think the key things here are, well, I've already said the key word, listening. People involved in organising services and working out what is needed can't do this alone. They can't do it in isolation. They've really got to get out and listen to people and understand what the concerns are, what the issues are, what the barriers are, and take suggestions on how to coordinate services and make care available to people. It can't be set up with a preconceived idea of how it should be done. It should be done with the help of the people who need that care. So that's the first thing to say. And that is something which is now starting to be written into policy, which I think is great. It's obviously just the beginning and we need to do a lot more work around that. But there have been some national initiatives around community champions and putting resource into that so that we can actually have people in communities to really start to talk to people and get those messages in. So that's a good first move. The other thing is around leadership in general. So we need people who are in the big policy positions to really have the drive and passion to do something about this. And one of the things that happened towards the end of last summer was that the NHS in general was told each organisation within the NHS needs to have someone who's leading on inequalities in particular. So whether that's a hospital, whether that's in the general practice setting, whether that's in the clinical commissioning group where I work, every single organisation needs to have somebody nominated who will really drive this forward. There are then some other things around how do we ensure that we collect the right data, because how can we possibly know if there's a problem if we don't really collect the right information to know what that problem is? So there's now a concerted effort to look at people who are accessing healthcare and those who perhaps aren't accessing it, and also outcomes. So where are people the healthiest and where are people the least healthy, and why might that be? And we all need to have a really good understanding of what that is so we know how to then go about tackling it. There's a lot to be said for prevention. So a lot of the illnesses we see, heart attacks, diabetes, a lot of these things could potentially be prevented. But then when you go, it's not just about when you've got those illnesses, how do you treat them? It's way upstream from that. So how can you support people to have the healthiest lifestyle they can possibly have? And that's not just NHS services. That's where you get the crossover with the council of how do you have access to green spaces so you can have exercise, you can have fresh air, and you're not breathing in pollution every day. You can have access to healthy foods. All of these sort of, good housing, good quality housing, not damp housing, all of these sorts of things that will lead to good, healthy lives. So these are all things which are now being put into policy from centrally, so which is really good because people are now listening and know that this has to happen. We're early stages, I think, in this. This is going to be something which, we need to get going now, but we need to now get the momentum going and sustain it. What I don't want to see is COVID come and go and then this gets forgotten. It can't be like this. The light has been shone. Now let's really run with this and really see how we can make a change now.
Thank you, Dr. Kiran. Dr. Amar, do you want me to come to you next? You did have your hand up.
Yes.
Taking it back down.
Thank you, Uton. It's a great question, my friend, and Kieran's done a good job of answering it. I think we have to be honest here that some of the inequalities come from wider societal differences. So one of the things we know is that people from a Black and ethnic minority background are likely to be from a lower socioeconomic background. And so as a result of that, we have poorer health outcomes. I'll declare my parents both have diabetes, high blood pressure. I come from a community where diabetes and high blood pressure is rampant. The COVID pandemic has highlighted that, as you've said. My father's best friend at the moment as we speak is on ITU on a ventilator. So this is a very pertinent question that you ask. And the fact is that it's unlikely that we will see significant differences or significant achievements made in a very short period of time. But what we must do is we must keep asking the right questions, and you guys must keep coming to these types of meetings and holding us to account and saying, look, what are you doing about this? Because actually, what you sometimes find in policy decision making and also politics generally is that the people who have the loudest voices may have the more attention focused on them. And I know this is publicly recorded, and that's not going to be the very politically correct thing to say, but unfortunately it's true. And so what we need to do is we need to make sure that communities which are underrepresented in certain areas come forward and they say to us, okay, what are you doing for my community here? And you need to hold us to account, and you need to come to these meetings and ask us, what is it that you're doing for our community? So as Kieran said, people are starting to take a look at this, put a focus on this. We know with the Black Lives Matter movement from last year, actually things are in a slightly different place. But we can't, expect things will change overnight. That unfortunately is not going to happen. But you must keep coming and holding us to account. I'd really encourage you guys, you've taken time out of your day to day, keep coming to these types of meetings, keep coming. It won't happen overnight, but slowly and surely we'll get there together. Thank you.
Thank you, Dr. Amar. And can I go to Dr. Mary to say a few words?
Yes, thank you very much. I agree with everything that has been said so far. And actually, I know some studies have shown that if there's been grassroots involvement. For example, Amir talks about people in this mosque. There's a study in America that if you have somebody with a cultural relevant experience engaging with you in your health, then you're more likely to have a better outcome than if you don't. So I think this grassroots supports, like Kieran said about leadership, and again, with asking questions and trying to push us forward, I think that's really the one of the ways that we can begin to change things. And I think, as Amir said also, it's not just for the people out in the community, it's us as healthcare providers that we have a patient sitting in front of us to be aware of this and actually find out and have that conversation to see how we can change things. And it's going to be a long road, but I think finally we started. So, yeah.
Thank you everybody for your time today, and thank you for your contributions.